So good afternoon, everyone. We're going to go ahead and get started. We are very excited about our discussion today and our guest speaker. I want to go ahead and start as we usually do around the state of the state and put a little bit of a different view because we probably, if you're tuning into the news, you know what's happening across the world, and we're seeing in the United States, we are over 32 million cases, and our death rates are pretty consistent. We have about 573,000 plus deaths now. But where we're seeing the surge is really in India, and we want to make sure that we're mindful of that because we've seen in our numbers that we're sort of reaching a better state where we have actually seen a drop in our percentage of new cases. When we look at the 7-day moving average for positivity rate across the United States, it's at 6.3%. As of April 27th, which was yesterday, the number of new cases was 47,691, and that is a significant drop. Here in Florida, our 7-day average for positivity rates is 8.97%. And when we look at what's happening across the state, we're seeing a drop in our cases as well. 5,280 new cases were reported on April 26th, and that positivity rate was 6.92%. We are also seeing that with the vaccinations and our SNFs, and the fact that we're vaccinating our residents, we're getting some really great results. The positivity rates for both staff and SNFs has been under 0.5% and is even lower than that. So, really good numbers. Where we're going now is when we look at what's happening across the United States. We are seeing that we've been able to administer over 232 million doses of vaccinations. In the geriatric population, that means there's 81.8% of 65 years or older who's received that first dose. For Florida, over 14.6 million have received, have been fully vaccinated. So, let me correct myself, over 14.69 million have had doses administered. The breakdown of fully vaccinated to one dose is a little different, and we're still getting those updates. One update that I wanted to share was that the Johnson & Johnson vaccine has been resumed. It was interesting. I was on the Colorado Medical Directors Association annual meeting, and I was listening to Dr. Nace as he was stating, stay tuned to the news. And at 5 o'clock, we saw that update. So I thought that was very interesting. Unfortunately, what we're seeing is there's still a lot of hesitancy, and we're going to talk more about that when we talk with Dr. Gaur. The other news is that the CDC came out with some new guidance, and I will, Dr. Gaur, make sure my husband knows this because it now takes away a lot of his reservations about getting us even an anniversary outing. So the CDC issued new guidance around outdoor masks and guidance for fully vaccinated people. And we know that this is something that we've been waiting for, and has a really huge impact with our facilities. So I don't want to steal any thunder from Dr. Gaur. I want her to be able to share some information with us. And for those of you who do not know Dr. Swati Gaur, she is the chair of AMDA's Infection Advisory Committee. She's also treasurer of AMDA, newly elected. She was one of our, I think maybe our second guest here on our journal club last year. And we talked about preparedness and how we were all losing our collective minds. So it's great to have you back. And if you want, you could go ahead and take the ball and share with us some information.
Absolutely. What a pleasure it is. And I mean, haven't we come a long, long way together So thank you for the opportunity. I mean, it's pretty remarkable actually to come today and talk about these things. I mean, yesterday I had put on my Instagram post, I mean, CDC is dropping guidance like Taylor Swift drops her album, you know? So it was quite, quite a celebration, and also, yes, congratulations on your anniversary. I think, like I said, you can tell your husband you got a gift from CDC. Of course, you gave a gift to yourself by getting vaccinated, So just wanted to briefly touch upon a few things. And, we all know it is very important to vaccinate, the staff, and that has been our biggest challenge. So I'll briefly talk about this and talk about why it is important and what we know as far as data is concerned, and then go into, the new guidance that has come out really yesterday from CDC as well as CMS, and, talk about these significant changes that we are going to be seeing in the coming days, or we will have to bring into our protocols, as medical directors in our facilities. So I will start sharing my screen, and let's see if I can. Share. Do you all see my screen?
Yes, you can see it.
Okay, perfect. So I just wanted to share a few slides. So why is it important for healthcare staff to be vaccinated? We know that our residents have gotten vaccinated, and a large number of our residents have gotten vaccinated. So I just wanted to share this modeling that CDC had done, their vaccine group. And on the left, you see, the healthcare providers, if they're vaccinated, if the vaccine efficacy, if all your healthcare provider are vaccinated, and if the vaccine efficacy was only 50%, then your infection and death rates, how they get affected as well, versus if the residents are vaccinated. And basically, what they showed is that the vaccination of healthcare providers results in greater reduction in both infections and death versus just vaccinating the nursing home residents. That is their modeling data that shows. So, if you had to do one intervention and you have the choice of either vaccinating all the, now this is all theoretical, all the residents versus vaccinating only the healthcare providers, you want to go with the healthcare providers because that is what the modeling studies have shown. Has it borne out in practice or in other data that is coming out? This is a study that was published, that is actually preprint. It was preprint when I got it. It is by Stefan Gravenstein out of Brown University in Rhode Island. And, he basically, they actually got the antibody titers. And if you look at it, the anti-spike protein, anti-receptor binding domain, and then they did the neutralizing antibody. And if you focus on this neutralizing titer, which is, what matters, the control is your healthcare providers, and your nursing home is the nursing home residents, right? And so they said, if you vaccinate the healthcare providers versus the nursing home residents, look at their antibody titers. These are healthcare providers. Look how much higher they are. And, this box is higher than this one. But look at these guys over here. There are some who are not able to generate as much antibody titer even after vaccination. So, this is something that we have to keep in mind. Now, these are, of course, convalescent, and, they are kind of at par with this. So it is, the two questions are being answered in this, I guess. One is, do I need to really get vaccinated if I have received, if I've already had COVID? I mean, this is the question that your families are going to ask you over and over and over again. And you can basically tell them that, this is just the control group. This is not even our residents. So your control group antibody neutralizing antibody titer is kind of similar to the lower antibody titer that is being generated in your residents. So the number one question that is being answered is, yes, you do need to be vaccinated. And look at these people who had prior SARS-CoV-2 and then got vaccinated, and look at how much higher their antibody titer are, right? So, so the two questions that are answered are, one, yes, you do need the vaccination. Number two is that, it is so important for your staff to get vaccinated, because, these folks here have overall, somewhat of a limited response. I mean, it's a great response, but, you got to protect these residents, and therefore it is so important for them to get vaccinated. So, this is, we talk about, Diane, you talked about vaccine hesitancy, and, this is an interesting, Kaiser Family Foundation did the study or survey, and basically found, who are people really listening to, right? And what they showed is that they are most likely to listen to you guys, the doctor, nurse, or other healthcare providers. So it's so important for us to continue to drive home that point, because what we have also seen is that, after these early people took the vaccines, I mean, change happens in a curve, and those early adapters, they kind of will go, and they will, those are the first people who will buy an iPhone when it is out, right? So as soon as the vaccine is out, there were some people who were like, yeah, I want to get the vaccine. I mean, I was one of them. So those are the people that are going to just go and take the vaccine. The middle ones are going to be the ones that are going to kind of see what is going on. We'll need a little nudge, we'll need some help in kind of climbing over that fence that they have created for yourself. But what you say matters to them. So it's very, very important. And and the other thing that I wanted to also say is, a lot of our frontline healthcare providers are people of color, and they do tend to listen to their religious leaders as well. They are a big influence. So that's the other strategy that we could kind of look into, is going and meeting the religious leaders and answering some of the questions that they have. And if you are able to, go and, deploy that strategy of really talking to these people who have influence in your staff's lives, that may be a good way to do it as well. Why is we talk about okay, so we got the vaccine and now we can go around and we don't have to wear a mask. And this is something that, Diane, you had talked about in India, right? There is a new variant that they're talking about in India. It's B.1.617, which is a crazy variant, because currently this is what we know. This is what CDC had put out. And so these blue ones are the pre-existing virus, the original COVID, right? And coronavirus. And as you see, the number of original coronavirus is going down significantly. I mean, look at the bars, right? So what is the story inside these stagnant numbers, or these low numbers, is the following. The original virus is actually going down, but what is increasing is the variants, and that is worrisome. So if you literally drew a line straight up, look where your curve is going. And now you put, so B.1.1.7, let me just talk briefly about that. That is your UK variant. And what we know about that is that it is probably more contagious than the original coronavirus. So, we have to look out for that. In our community, for example, we are seeing that B.1.1.7 variant, as well as we are seeing the South African variant as well. So it's important for us to know, which variants are in your community. And then the P1 is the Brazilian variant. So, this tan line is your B.1.1.7, and then your B.1.351 is your South African, and then your P1 is your Brazilian variant. And there is no doubt that we are going to start seeing some other variants as well. we know that the vaccine is actually fairly effective against any of these variants. Of course, it's if in the variants it's most effective against the B117 is the data that we are getting right now, and then of course, the more mutations there are, or the specific mutations in the South African and Brazilian variant, they tend to want to blow through the immunity. So to your staff members who are just wanting to take the first shot of Pfizer or Moderna and say, I'm good, the variants, the Brazilian and the South African, and once we get the Indian variant as well, we expect that it's just going to blow through the immunity, that like as if it's not there. So you got to be prepared for what you're going to be dealing with. All right, so we were so excited about this, the guidance that CDC has actually come out with, and the CMS has come out with. I mean, I literally have it all in papers and am frantically underlining and highlighting, because we are going to want to implement these guidances. And we have been kind of, chomping at the bit to bring some of this guidance, because it's very much based in what the data is showing us. So what is the background of this guidance from CDC is basically CDC, from their data out in the field, is gaining a lot of confidence about these vaccines, on these vaccines. And basically it's showing how confident CDC is in the effectiveness of these vaccines. So I am very much welcoming of the new guidance that they have come out with. Now, that guidance affects pretty much all walks of life in our nursing homes. So to operationalize this is what we did. And I'm sure that there are many good ways to operationalize it. But because there are so many different things that we are finding out that we are going to want to change or will have to change, today we deployed our staff guidance that is very specific to staff. And that is also, staff 1.0 today. So I'll briefly go over the new changes that you anticipate seeing in your facilities. I think a lot of them are going to be very welcome. But let me just go ahead and start. So, the way that I divided it is testing requirement changes, quarantine changes, dining and meeting changes. So fully vaccinated, the new guidance basically puts fully vaccinated staff and residents, and really, is speaking to the safety and the decrease in transmission as well of and acquiring COVID in these folks. So there is a clear line drawn between what do you do when you have unvaccinated people in the mix, what do you do when you have vaccinated people. So if your staff is fully vaccinated, which means 2 weeks after your second shot, and your staff doesn't have one of those immune, low immunity conditions, and CDC has clearly talked about those low immunity. If you are on current chemotherapy, if you have had bone marrow transplant in the last 1 year, if you're on immune modulating agents because of that, etc., you are going to be that high risk individual, and you're going to be in that unvaccinated unvaccinated staff pool. But for fully vaccinated staff, the following has changed. So when we do testing based on your community prevalence. So for example, we were at 3.8, I think is the lowest that we went, and now we are going up. Again, going back, Diane, to your point of we have to be very cognizant of what may be going on in our community. We went to 3.8 and people are like, yeah, it went away. Well, no, it's coming back. And what we are seeing is, again, the numbers are creeping up. So we are at 5%. We are supposed to get our testing done once a week. Fully vaccinated staff members do not need routine testing. So people who are getting, with your numbers, I believe you would also be getting tested, once a week. fully vaccinated people do not need testing, routine testing. Now, symptomatic staff needs to be tested immediately. Outbreak testing needs to be exactly what we were doing. So everything else stays the same. Routine testing, fully vaccinated staff does not need to be tested. What does that mean for the facility? Facilities need to keep accounting for staff members who have been fully vaccinated. That is very important. This is something that, our HR department basically was telling us, that you cannot ask for vaccination status. Well, now CDC and CMS both are basically saying it's the facility's responsibility to keep track of the staff who is fully vaccinated. And in fact, we just had a survey, and they asked for a list of staff members who were fully vaccinated. So it's important for you to do that. Now, the way that we have tried to make sure that we are, of course, making sure that PHI, their privacy, our staff's privacy is ensured, is our infection preventionist, who is also doing the job of employee health, is keeping a track of that, and our DONs, because they are going to be the ones that are making sure that people are getting appropriately tested. So only they have access to the list of staff members who are fully vaccinated and people who are unvaccinated. So that is the number one change that we are seeing, and that has been implemented in our facility as of today. Quarantine requirements. If your staff member has had exposure to a positive patient, a big exposure, they don't need to quarantine. They only need testing. So if I had an exposure, I'm fully vaccinated, I had an exposure, an unprotected exposure, I don't need to sit at home for 14 days. I can come to work. I need to monitor my symptoms. I need to get tested immediately, then on day 5, and then one more time. But once you are done with that testing, you're good to go. So they don't need to take PDOs. So that's an important change as well. Dining. Fully vaccinated staff members can take break together in break room and dine together around a single table. That is a huge change from what we have been doing in the past, year. Meetings. If your team is fully vaccinated, you can actually now sit around the table and have a meeting. So these are important changes that CDC is now recommending. And what we have done is we have taken the first part of it, testing and quarantine, and we're going to implement that. And then we're going to talk about dinings and meetings tomorrow, and slowly bring that into effect. Let's talk about residents briefly. Testing requirement for residents. Of course, residents are not supposed to be tested routinely. I mean, I know that there are some states who were requiring the residents to be tested routinely. That is not appropriate. That you need to only test the staff routinely. Testing of, quarantine testing, outbreak testing is going to be the same. We have to have very, very, one thing that I've seen in our nursing home is this is a balancing act. We are looking at variants in our community. So one of the things that I noticed is, since we didn't have an outbreak for a long time, our facility kind of, people get complacent. So if somebody is having nausea, for example, or they are having some shortness of breath, we need to kind of come back and really heighten our sense of the typical symptoms of COVID and have a very low threshold of testing people. So that is because we are now doing more visitation, and we are now making our facility a little vulnerable to the variants. So we have to continue to have very strong clinical surveillance, and testing thresholds should continue to be very low if there is a clinical symptom. Quarantine, very important. What CDC has come out and said is, now you're going to start seeing fully vaccinated residents coming in as admissions. Fully vaccinated residents who are coming in as admissions do not need 14 days of quarantine. That is a huge change from that 14 days of quarantine requirement that we had. So we had a few patients like that. And actually, I was going to reach out to CDC and say, we feel like you can really mitigate the risk by vaccinating. Somebody is fully vaccinated, their chance of acquiring COVID is fairly low. So could we change this quarantine requirement? The caveat is they should not have had an exposure to COVID while in the hospital or any time in the 14 days prior to getting admitted to your facility. So that's an important caveat to bear in mind. Dining. Fully vaccinated residents in communal activities like dining and other activities can have activities that are unmasked around a table. So for example, if your full cohort of residents who's playing bingo or who is dining together is fully vaccinated, then they can sit around a table and dine. And they can play bingo unmasked. However, even if there is one person who is unvaccinated in the room, everyone will have to mask. So that is an important change that we are going to start seeing. Quickly, I think this is my last point. Visitors, place of meeting is important. CDC is basically saying, try to have that meeting in an outdoor environment. So, that is something that we have been trying in our facility. We are not allowing the visitors to walk through the facility. What we are doing is we have designated indoor area that gets, fully decontaminated after, fully disinfected after, the meeting has taken place, and we are scheduling in that inside area, but our preferred site of meeting is outside. So we have several outdoor designated benches and, tables, etc., where our visitors are meeting our residents, because again, it is important to risk mitigate from that standpoint. Type of meeting. If there are two fully vaccinated people meeting each other, like husband and wife have been fully vaccinated, the husband is coming from outside, they can sit together, have close contact with each other. So that is something that basically CDC is saying, is that you got to make a determination whether fully vaccinated, close contact with each other, one person fully vaccinated, one person not fully vaccinated. It depends on, what this person who's fully vaccinated wants, your resident wants. However, the recommendation is that you do keep that risk in mind and let them know that there is still a risk that they will, that they are exposed. So the risk is higher. Unvaccinated, of course, the risk is going to be further more. So yeah, so these are basically the changes that CDC has kind of put in place as of yesterday. Diane, I just wanted to go over these changes and let's talk.
Yeah, those are a lot of changes. I think there was a request to have you go back through the quarantine stuff, because that's something that it's just, everything has changed.
I know. I know. Here is what I would say. I mean, the only way that we are trying to make sure that we are following the changes appropriately. So because of that, we have decided we are going to do it in a stepwise pattern and not try to implement every single change, because it's going to be a mess if we are not smart about it. So you said that,
yeah,
go ahead.
We had a question because one person's facility said they have to await CMS approval of the new guidelines before applying it to the residents. Can you speak to that?
Yeah. So I had emailed Kara, who is the head of long-term care in CDC, long-term care division in CDC, and I said, when is CMS gonna change their guidance? And she sent me the CMS guidance, and I can actually send you the links Yeah, it came out yesterday.
Mm-hmm.
It came out yesterday. So they are absolutely lockstep with each other, which is lovely to see, actually.
You
So,
mentioned, yeah, you mentioned something about having your the survey and the surveyors asking about this, and I really want to maybe unpack that a little bit. What do we need to anticipate if we're getting into our survey windows? What do we need to anticipate about how they look at outbreak now, given some of the studies about the fact that we sort of follow what the community is doing and we're getting our residents vaccinated, but you may have staff who's not vaccinated. And just to put a little bit more color on that, there was a big the New York Times how a staff facility. So what do we do? What are they saying about all of that?
So, surveyors are now, like I said, we had our survey just happened last week, and it was a great survey, thank God, and kudos to our staff. But they did ask us, HR has been pushing us, pushing back on us, saying that, you cannot have different policies for different people. But, when CDC comes out with stuff like that, it makes sense because, it helps us push that, smarter policies through. So I think that is a good thing. They definitely asked for who are our staff members who are fully vaccinated. So they do expect you to keep a list of that, which was new for us because we are always kind of worried about our staff privacy and medical record privacy, but this is something your surveyors are going to ask you for, and it's clearly written in CDC. In fact, I kind of underlined it in red because that is definitely different from what we thought that we were supposed to do. So they expect us to keep that list with us and updated.
Can you go back and talk again about the testing? So if we have the majority of our, like say all of our physicians are vaccinated, they're fully vaccinated. They are no longer, depending on the rate, no longer have to do the testing either weekly or some counties bi-weekly because they're fully vaccinated. Because you're about to make a lot of people happy. So
I know. I know. I mean, and I will be honest. I mean, a lot of our senior leadership team and staff members, they are all vaccinated. And we have kind of hit a roadblock here with, we are actually providing vaccination to our staff once a week. We are opening up clinics once a week because, you have to, of course, open that valve. We cannot do it every day. Mm-hmm. We are making sure that we are doing it on Wednesday. So every resident who is a new admission gets asked if they have been vaccinated. If not, the physician or the nurse practitioner are counseling them and answering all the questions regarding vaccination, figuring out if they need the vaccine. Then they are getting put on the list. So our strategy to keep COVID out and keep the outbreaks to the minimum has been, as soon as that person hits your door, you ask them about the vaccination. Within that first week, you should be able to vaccinate them. Mm-hmm. So we're also going out and asking the staff members, and CDC clearly says that you should continue to, they have very good language, actually. I'm gonna read verbatim because this was important to me, what they had written. So facilities should continue to promote and provide vaccination for all healthcare providers. So ongoing, push is very important in this case. We talked about vaccine hesitancy. It is going to your nurses and, even in the ward and talking to them, in an open, non-threatening way about how important vaccine is, what great studies that are coming out, for vaccine effectiveness as well as vaccine safety. even with the J&J, when that happened, people are like, well, we knew, blah, 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 blah. And I'm like, this just proves to you that CDC has a very tight control, control over what they are doing. So I took that opportunity. I mean, we need to take that opportunity to educate the staff and say, listen, this is a proof that CDC is getting the data, getting all the data from everywhere, looking at the data, looking at the signals. And if there is a signal, they are not hesitant to put a pause and look if there is seriously a problem or if this is something that they can overcome. I mean, what better example than the J&J vaccine, pause to basically say, we really are invested in your safety, right?
That is so true. And I had the experience of having more people that I knew had my cell phone number call me and ask about what were your thoughts. And given that my daughter and my husband, that was the shot that they received, and like, it is okay, you have none of these symptoms that they mentioned, and there is people who are observing everything that we get in. And I think that is the leading strategy. What we're doing here in Florida through the FMDA is we're starting a vaccine hesitancy strategy. And I think everything that you're sharing is even more reason that we could go back to the staff and say, this is why we need you to be vaccinated. This is how we get back to the new normal.
Yeah.
Yeah.
Yeah, absolutely. And one of the ways that I love to garden. So you'll see a lot of gardening analogies. A lot of people in Florida, I think, love to have your front yard and your grass, right? Your yard has a lot of grass. And I'm like, it's the same way. If the weeds will grow, if your grass is not healthy, right? So you got to make sure that your grass is healthy. Basically, the misinformation will grow if you don't put out enough information. You got to put out real information constantly, keep updating it, but keep talking to your staff, because I can tell you, Diane, every single time I've gone and talked to the staff, you feel as an educator, I feel, you always have this, I don't know, an idea that when I talk to the staff, they should be able to change their mind. Minds don't change, may not change immediately. That needle keeps moving though, and that is one experience I'll share with you. I talked to one of my kitchen staff, and he was a person of color, and I talked to you and I said, I'm really worried about you, let's talk. And we had a one-on-one conversation. It was a non-threatening conversation. We talked about so many things. We talked about the Tuskegee trials. And I said that is real. That is real. And I was concerned myself, and look at this data. I mean, the vaccine studies have had, 1 in 10 were African Americans. So, that makes me feel better about that. There is no difference in the efficacy and, safety of the vaccine between any races. And then, we also talked about, why is Bill Gates involved? Is there a microchip? You still have to approach it with very respect. I mean, because that's real for them,
It's
but
the information that they're receiving. So yes.
Exactly. So, I had that conversation, and I'm like, came home, I'm like, I spent this 1 hour, for sure he's going to get the vaccine tomorrow. Well, that didn't happen, and I'm like, oh, sometimes you feel like you failed. But then, and then I'm like, I forgot it, and, you keep moving on. But then, after we had our annual meeting, when I went back to the nursing home, I called the nursing home to get an update, and there he was. He's like, Dr. Gaur, I just wanted to let you know I got my first shot, and I did it back, for you. And I mean, it's incredible that every time every time we are talking to our staff, it is moving the needle. We just need to be so aware of that. And I'm like, yeah, you really did it for yourself, but it made me so happy, right?
No, but it's being aware, being sensitive. I think some of this, the misinformation, it is not just in one culture. It is going across people who we would call like lay people who are not into the sciences. Sometimes it's even in with doctors and nurses, and I think it really comes from being from a place where you have to let people know that you are so grateful that they are here and that we really want you to stay healthy. And that has been how I led every conversation, because I really want you to stay healthy. I do not want to lose another person who I know to this, especially when we have tools that can work. I want to shift gears and ask you a question about, because sharing with all the different variants and talking about the variant in India, my concern is, how effective are the monoclonal antibodies against some of the variants? Do we have any information beyond what we saw with the FDA talking about BAM not being able to be used in isolation? And I call it BAM because I will never be able to pronounce that correctly.
me as well. So I think, is there plenty of data against the variants? No, we don't have a lot of data against the variants of these. However, this is a very important strategy, and I'm so glad that you brought that up. So basically, if you look at the strategy in the nursing home, I always talk about, what is your percentage strategy, of what we are doing to keep our residents safe. So, of course, right now, your 70% is vaccination. So, I always tell 7 in 10 effort should go into vaccinating our staff and our residents aggressively. Masking and PPE use is right there with it, but BAM plus ETI, I'll just kind of have nicknames for everything because God knows I can't. If I said it like 100 times, I would be able to, but why? Hopefully we will not be, we get people vaccinated, we don't have these outbreaks, but we may. So that is an important strategy to have in those residents that you would go and talk, and they would still say, I don't want the vaccine. So we had actually, an outbreak in vaccinated residents. The good news about that was that we had 4 residents. So we had 1 staff member who was unvaccinated who tested positive. So then we did testing of the whole entire facility, and one resident tested positive. He was already vaccinated, fully vaccinated. And then two more residents tested positive after that in the next go round. So they were also fully vaccinated. The good news about that, I guess, is basically none of them had. So I said, I want the sequencing. I want the sequencing of this. What virus is this? Why are we getting that outbreak? The CT values were so high on all 3 of them that, we could not sequence them. I guess that is a bad news and a good news, because I would have loved to get the sequence. But the good news is, if the CT values are that high, I'm not sure if they could even have transmitted to somebody else. So, so it's a hopeful thing when, people are getting, outbreaks. Most of our residents are getting outbreaks where the CT values are super high. So we don't see this, that crazy transmission that we saw in the nursing homes. We are not seeing that kind of crazy transmission in fully vaccinated people. We did give one of our residents, he had nausea and vomiting. We were not sure if that was really related to, he had many other medical problems that were going on. And we were not sure if it was really related to COVID, but because he had mild symptoms of clinical symptoms of COVID, we did end up giving him the combination. So either use of Regeneron and the 2 combination of that, or the BAM plus ETI is an effective strategy for you to have. If you have these breakthrough outbreaks, or there are residents who are completely refusing to take the vaccine, and you get, and they get positive. So
let me ask, when we're thinking, okay, if we're in that position, like as you were mentioning, what do you do first? If you're the medical director of the building, or even an attending and a clinician in the building, and there is an outbreak and you want to request sequencing, you want to know, track back to which hospitals, all of that. What is the first thing that you, the infection preventionist, the DON, what is the first thing you're doing?
I mean, the first thing is that, as soon as we get somebody positive, everyone goes into isolation, right?
Yeah.
You quarantine everyone. And then you start, we have developed a very strong contact tracing kind of, because we were keeping track of all the personnel who were working in that unit. So what we do is you immediately test everyone, right? You stop the visitation, stop the facility, except for truly end of life visitations, you just stop everything. You completely, from an infection control standpoint, this is the absolute key. This is like the absolute thing that you have to do. Mm-hmm. You are going to want to completely block off the units, right? Whatever happened, whichever unit it arose in, or your staff worked in a particular unit, that unit needs to be completely isolated, complete cohorting of staff, residents, equipment, and shut the doors down. I mean, that is the strategy that has worked, whether you have vaccinated people or unvaccinated people. And if you don't do that, your facility is going to be in a mess. So that is our number one strategy, is shut all the doors down and no passing through the doors. I mean, we have had food carts that have to go take a meandering road because, our facility is one of the older facilities, but we do it. We do it because we know that that works every single time. Then you test everyone, and basically CDC has said, you test everyone, or CMS as well. Test everyone immediately, test everyone within 5 to 7 days of that first test, and then 5 to 7 days of the other test, until 14 days are up, and then you can lift the, quarantine for everyone. So that is basically your strategy. Also make sure that you have a place, even if you don't have people who are testing positive and you have been out of outbreak for a long time, at least have those 2 or 3 or 4 beds where you can completely cohort these COVID patients. Because it may happen. It's coming to your neck of the woods, and you don't want to be unprepared. So you do have to have that, contingency for cohorting.
What happens to antimicrobial stewardship? What has happened during this pandemic? All we've been talking about is COVID, as if that's the only thing that exists. And we are seeing in some buildings more antibiotic use. I don't know, I'm not there hands-on, so I'm going to put you on an antibiotic empirically. What has happened to all of our strategies?
I mean, they have gone out the window. I mean, I think we're going to find that we're doing a lot of panic antimicrobial use. And one of the things that I had talked about when we had the annual conference is really co-infection or superinfection or bacterial infection during or after COVID is of the magnitude of like 14%, 13-14%. But we are giving antibiotics at very, very high rates, over 40% or 50%. I need to pull that data, and I'm happy to send that data. I may be kind of off a little bit on the numbers, but the co-infection is very low, very low. And the problem is that people who have had lung involvement in COVID, their X-ray for a long time is going to look like an infiltrate, and bilateral infiltrate. Yes. So every time there is something going on with that person, if they are coughing or something is happening, I mean, we have to come back to that Loeb's minimum criteria use, and then plan on starting an antibiotic. Resist the urge to treat X-ray, because X-ray is not the patient.
We're seeing those changes 6 and 12 months after.
Absolutely.
I've had people call and say, I need an antibiotic, or I need that special cough syrup for this person. Like, you don't need a special cough syrup, no opioids and no antibiotics. We need to just stay the course. Let me give you some other symptomatic treatment. But yeah, I think there is a trick. We're in such a crisis mode still, and maybe that's the issue. We're practicing still in that crisis mode, even though we're seeing declines in rates and everything else.
Absolutely, absolutely. Now, one of the things that, while we have, so a couple things that I will say about antimicrobial stewardship. One, that, while as physician, I continue to, take care of COVID, and you can't do it all. Empower your antimicrobial stewardship team. And for us, I have made our consultant pharmacist, the champion of that. So first of all, have your antimicrobial stewardship program pretty steady, right? So we have, based on the antibiogram data that our local hospital gets to us for our patients, we have assigned, these are the preferred antibiotic choices. So we have that PDF that we circulate heavily among the nurses who call people, and who call the clinicians, and the clinicians as well. We make it available. We talk to them as soon as they are onboarded and yearly about the antimicrobial stewardship program. And then we have the consultant pharmacist who is kind of going back and saying, you know what, are you fulfilling the McGear criteria? Or was there a low minimum criteria that was fulfilled before this antibiotic was started? And she is basically turning around and saying, oh, I see that you started Levaquin, but our choice of treatment based on our protocols is really Augmentin. Would you mind changing that? And the duration as well. So, they are the ones that are monitoring. So it's basically, we are working as a team, because our infection preventionist who would otherwise do that is so busy with COVID stuff. And we are busy with, all these clinical conundrums that we are getting. So empower your antimicrobial stewardship team to question the clinicians and talk through some of these decisions. That is going to be very important. The other thing is telemedicine, right? One of the studies that, I talk about cellulitis, right? Most of the antibiotics in long-term care are given by people who have not seen the patient. Now you have telemedicine, right? See the patient.
Yeah.
See the patient, see that leg, see that wound. I mean, I have today a patient, they're like, Dr. Gaur, it looks like cellulitis. And I'm like, you know what? I have a FMDA meeting from 12 to 1. How about we Zoom after that? So take that 5 minutes, 10 minutes, 15 minutes, or make it a visit and bill for it by all means. But look at that wound. Now, with telemedicine, that's the bright side of, having COVID. You have that opportunity to see a patient prior to starting antibiotic.
Yeah, it really has evolved what we need to do. And you sort of led into my final question about where do we go? Where I see that we have in the American Rescue Plan, there is information about supporting nursing homes with strike teams and supporting infection control, but it really feels like the onus is on us. How do we move it forward? What do we need to do to evolve infection control and really make it what we need it to be as we've learned all of these things from the pandemic?
Absolutely. I mean, COVID, I don't know where COVID is going, right? It may be another flu, but we still have flu, right? It's funny. Yesterday, my infection preventionist called me. She's like, Dr. Gaur, we did this test, the full-on test, the panel, and now, parainfluenza is showing up as one of the viruses. What should I do? And I'm like, isolate them till 48 hours after the symptoms. Take the same isolation that you have learned from COVID that we were wanting to teach ourselves, for flu.
Yes.
Take that and apply it. Now you know what to do, So I think there are a lot of good lessons that we can learn from this moving forward. Use of enhanced PPE in infections, MDROs that are of concern, etc. It's just it has made us realize that when we are, really asked for it and we have a will, we are able to step up to that task. So it's, I am seeing a lot of silver lining these days. So
well, I thank you for this conversation you made. This has been the funnest meeting I've had today. And I'll definitely tell my husband that I got a gift from the CDC. Thank you, everyone who listened in. We will make sure we get all these slides uploaded, get the links to you as Dr. Garson sends them to us. And I thank you all.